Hello, my name is Nancy Warden. I'm an associate professor in the Department of Pediatric Research at the University of Texas MD Anderson Cancer Center Children's Cancer Hospital. So I will thank you for the opportunity to present my work. And I would like to start by emphasizing that one of the major concerns of this lethal disease, osteosarcoma, is that there are no good treatments for recurrent metastatic disease. So here we offer an opportunity for an alternative treatment that might improve the survival of these patients. Osteosarcoma is the most common primary malignant bone tumor in children. It is still a very rare tumor with only few cases diagnosed in a year in the US. And as you can see from those, 400 affect populations less than 20 years of age. However, the rarity of the tumor, the complexity, the big heterogeneity of these tumors makes it a very difficult disease to study. And so osteosarcoma constitutes about 6% of all childhood cancers and about 35% of all bone cancers. However, I like to emphasize that only 400 new cases appear per year in the AYA population, but for those 400, about 20% of those, which is about 80 cases, present with metastasis of diagnosis. And this really constitutes a poor prognostic sign, as there's a treatment failure on these patients of about 85%. In addition, 50% of those 400 new cases relapse, and 80% of the relapses occur in the lung. And this is really the major cause of death of these patients. So how do we treat the patients now? We use chemotherapy, then we take the patient to surgery for limb salvage procedure, and then give additional chemotherapy. It usually takes care of the primary tumor in most of the cases. However, the patients are left with significant side effects due to chemotherapy. And one of the major ones is cardiotoxicity and nephrotoxicity. In addition, patients come back with relapse, and in 80% of the cases, relapses occur in the lung. And there are really no good therapies for relapsed recurrent disease. And in addition, treatment is very expensive. We have therapies to offer to these patients as an alternative, but none of them have shown significant benefit. So I would like to point to you the highlighted regimen there, gemcitabine and docetaxel. And the reason is because gemcitabine and docetaxel are the National Comprehensive Cancer Network recommendation for patients with second-line therapy with patients with osteosarcoma. However, it has shown, as I mentioned, very limited efficacy. We previously demonstrated in our preclinical studies using a murine osteosarcoma mouse model that given aerosolized chemotherapy with gemcitabine has significant therapeutic efficacy. As you can see, it decreases the number of pulmonary metastases. However, we also showed that gemcitabine induces a process that is called autophagy that conveys resistance to chemotherapy. So we thought that if we give an agent able to inhibit autophagy, we might enhance chemotherapy efficacy. So indeed, we choose hydroxychloroquine, which is an already approved, FDA-approved drug for the treatment of other diseases, and adding this hydroxychloroquine with gemcitabine, we showed that there was increased significant benefit in treating these osteosarcomas. So we hypothesized that adding hydroxychloroquine to the already standard gemcitabine and docetaxel regimen might enhance the survival of these patients and will increase the 4-month disease control rate, and in addition, will not add toxicity to the already established regimen. So based on this, we designed a phase 1/2 trial of gemcitabine and docetaxel in combination with hydroxychloroquine for patients with recurrent metastatic osteosarcoma. So this is the design of the study, but what I would like to point out is that we're currently enrolling in phase 2 dose expansion. We're planning to enroll a total of 25 patients during this phase 2, but what's most important for us is that we really need to do biopsies in these patients pre-treatment and non-treatment, as these biopsies will help us better understand why certain patients may or may not benefit from the treatment, and in addition, identify potential biomarkers of response that could be used to select patients for these or any other clinical trials. We're planning to complete these in 2 additional years. So we're really asking here for support on our patient biopsies. This is very important for us to really understand the benefits of adding this third drug. And we're very committed to the completion of the study. And indeed, the institution had reported initially biopsies in those patients, but because of COVID, these funds were cut. So the funds that Cure Within Reach offers are critical to inform clinicians of a potential effective therapy for patients with recurrent relapsed osteosarcoma that will learn from these biopsies. So the team conformed and from this study is a very strong team that has 3 physicians, Dr. Livingston, which is responsible for the design of the study with a strong background in osteosarcoma. Dr. Planeman and I are the pioneers of the preclinical studies that led to the design of these clinical phase 1 trials. So the overall impact, we believe that there are very limited treatment options for these patients with relapsed recurrent disease in the lung. Using these 3 drugs that are already approved by the FDA and are commercially available will allow us to get these treatments readily available to all patients with recurrent metastatic disease in the short to medium term. So with this, I will end, and I will thank you again for the opportunity to present my work.